Hello, thank you for joining us today. We are so pleased to have you all here with us as we round out our four-part series around consent and the opportunity for California to modernize consent to share. I just want to point us to a few housekeeping items. All attendees will be on mute. Please use the Q&A text box to be able to put in your chat or your questions. The webinar will be recorded and we will make sure to hopefully get to all of your questions. And if we are not able to, we will do our best to answer those questions offline and we'll send that out with the recording. So hello, everyone. I'm Timmy Leslie. I am the president of Blue Path Health, the consulting firm in the San Francisco Bay Area, and also the executive director of Connecting for Better Health, a collaborative to advance data sharing in the state of California. I'm pleased to be joined today by a real team of experts and also joined with our partner with Stewards of Change, Daniel Stein, who will be helping to moderate today's session. Today, as I said earlier, we are the last of a four-part series that reviews the recommendations of a white paper that was published last summer through the work of the partnership with Stewards of Change, as well as Blue Path Health and the California Healthcare Foundation. So I point you to that paper if you haven't read it. It is really the anchor of the work and of the webinar series, education series that hopefully you've been able to take part of. Just to introduce Daniel, he is the president of Stewards of Change. They are a think and do tank. I love that. And the work that they do, they really have a federal or a national viewpoint of interoperability and cover process, procedures, as well as technology. So we're really pleased to have their expertise and Daniel's expertise to be able to help moderate today. It's been a real pleasure working with him and his team over the course of this work. And as we were preparing for this, I think we were able to put our heads together and say, let's tackle consent, especially for California. We have such a huge opportunity with the data sharing framework to get this right. So Daniel, I'm going to hand it over to you as we really tackle this last piece around the technology that's there and the standards that are there to be able to help us down this road. Take it away.
Thank you, Timmy. Thanks for everyone for joining this call today. I also want to thank California Healthcare Foundation for sponsoring and supporting the work and their persistence in all of these difficult topics and challenges that they keep supporting. I also want to acknowledge and thank the folks who helped research and write and edit this report. And it's a piece of work that we're proud of, and we hope it has some persistence in the field and it's helpful for folks. I'm just going to set the context for a few minutes, and then we'll do some introductions of our four illustrious speakers, and then dive into some questions. So as you may know, Stewards has been involved in data sharing and interoperability across human services and healthcare for much of the last 2 decades. California has been one of the places we spent the most time working. And in fact, in 2014, we helped the state develop their interoperability strategy, which was a really significant piece of work to guide the state going forward. At that time, as you can imagine, privacy and confidentiality were identified as some of the key hurdles. They persist today as well. And we're really delighted about the opportunity to really dive into this topic here. We've been focused very much on this issue of consent over the last 3 years, in particular, since COVID started. And we're delighted to be able to work together to try to bring some of the best practices and latest thinking to the table today. And I'm delighted to say that while the wheels of progress grind slowly, progress is being made. And California's persistence over the last 10 years is both admirable and also exciting as it is poised to take a leading role, as well as some other states across the country, as we'll hear about, including Washington, Colorado, New York, Maryland, Rhode Island, Florida, and some others. As Timmy said, in the last 3 webinars, we've covered some really core parts of consent. As we know, consent is a hydra-headed problem, lots of different areas of it. First one was on a universal consent form, or Ask Me. Second one was on the legal aspects, and the third one was on identity management. All those pieces need to come together in order to address consent in some actionable way. Today, we'll be examining some of the key enabling technologies and some of the standards that are necessary to implement and enforce consent once it's been obtained. Now, here's a spoiler alert. This is not a 1-hour conversation. We're going to introduce some topics. There's a lot of detail and a lot of, hopefully a lot of technical information that we're able to describe, but there's a lot that's behind this, of course. And we also need to start with some definition setting. We need to distinguish between consent for treatment and consent to share data. Sometimes these things get mixed up a little bit. Today, we are talking about the consents that are needed to share data, and in particular, protected information, not treatment. So we are also not talking about the actual data sharing today once consent has been accomplished. That's a topic for another consideration. Many of the technologies are relevant to that, but the focus here is on that front door. And if we can bring up I think the one slide we have here, I want to just set a little context, because consent, depending on where you sit, you see consent from different perspectives. And this is just a sort of a visual mnemonic for us to think about, because consent is required for data sharing in different ways, in different areas that we think about, whether or not it's for research and analysis, or eligibility determination, for clinical trials, those kinds of things. We're really focused here on care coordination and the actual data that needs to be shared. And that's the most challenging and most stringent parts, and the requirements that are necessary to make that happen. It's important we think about that and keep that in mind as we're having conversations, both internally with the attorneys, the privacy officers, program and technologists. There are definitely a few things to keep in mind, and knowing which part we're talking about will only be helpful as we get into the conversation. Now, consent for care coordination has some of the most stringent requirements, as we know. We'll be talking about some of the key technologies and standards that are needed to enable data sharing and for security, identity, confidentiality, and important equity, because it all starts with equity and providing people the ability to say yes or no about sharing their data. We also hope that the technologies and the standards are replicable, so other states and counties and communities can take advantage of that. We'll also be talking about granular consent that is necessary for enabling the exchange of protected information like substance use disorder, mental health, women's reproductive health, DV, domestic violence, and HIV/AIDS. And some of the standards that support that, including HL7 FHIR, data segmentation for privacy, and also some work on granular consent that's being championed by Shift, which is a volunteer group of subject matter experts. There are a lot of details behind those things, and some enabling legislation, AB 352 in California and AB 1011. Madison's going to put those in the chat for you to dive into those when you have some more time. We're going to, with our panelists, explore some of the critical issues, what can be done today, what the future investments are needed to advance consent technology. The last few words before we dive into this, I want to share my enthusiasm and excitement that seeing some real encouraging developments that have really occurred, particularly at the federal level. One is the sustainable funding that we heard about and that we know is happening. So through CMS and the 9010 FFP, there is funding to do this work going forward. And Washington State, I believe, is the first state to have received approval for their consent-specific RFP, which is great to know that there's an end, starting with the end in mind. Another point here is the Office of National Coordinator has expanded their mission to include human services, which is amazing and great. And Stefan, who's on the call, will talk a little bit about that, as well as the Chief Data Officer for HHS, which recently released their data strategy for the next 5 years, which actually provides great guidance on data sharing and also recognizes the importance of consent, which is great to see that in the federal document. I think the bottom line is consent is kind of coming into focus It is achievable, and we really hope that we can support digital computable consent. It's no longer a concept. We're seeing real tangible progress in that area. So with that, I would ask our speakers and our panelists to come on onto the video. Turn your camera on. Or I think we have our pictures first, and then we'll bring them in. So our four distinguished panelists, all subject matter experts, deeply involved in this work. You probably know many of them already. I'll just give a quick bio for them, and of course you can find them on LinkedIn, and we'll include their bios in this work. I've had the great privilege of working with Kathy Miller, who's the Chief Operating Officer of the Bronx Rio, doing some of this work. The Bronx Rio, under Kathy's leadership, was a CMMI Round 1 awardee to develop health information capacity for data analytics and support quality improvement. And Kathy, of course, has a successful record in leadership in the hospital and community health settings and program development. And she currently works at the intersection of health and social needs for population health and improving health through health information exchange. And we're really glad that Kathy's here today, specifically working in the Bronx Rio. Mark Savage is the Managing Director of Savage & Savage and a leader in healthcare transformation through electronic information exchange. And Mark has been a stalwart in this field for a long time. He serves as the policy advisor for SDOH and the Gravity Project, we're all familiar with, and serves on numerous policy committees under the Office of National Coordinator. He's also worked for years on patient advocacy and stewardship issues, co-chaired the National Quality Forum's Interoperability Committee, and also served on California's Data Exchange Framework and Stakeholder Advisory Group. He provided congressional testimony and many, many presentations on this work. Thank you as well, Mark, for joining us. Dr. Mohammed Jafari is an independent subject matter expert in security, privacy, and interoperability, as well as consent, and has a decade-long experience working in the HL7 security group. Currently, he chairs the community-based care and privacy and human social services work groups. He's led projects like fire data segmentation for privacy and the implementation guide and consent at scale for the fire task force, and we'll hear a little bit about that as we go forward. And last but not least is Stefan Konya, a colleague from many years ago, and a leader and a real proponent of this work at the federal levels. Stefan today is the senior advisor to the Deputy National Coordinator for Health IT, and maybe I can say, and Human Services, and innovation portfolio leading at the ONC. Stefan shapes agency policy, long-term strategy, and serves as the primary liaison with the White House Office of Science and Technology Policy and external healthcare startups. He also leads the Digital Health Innovation Workshop work group under the Federal Health IT Coordinating Council. And part of that is coordinating with 40 other federal agencies. So he's really been a key proponent and partner in this work as we've gone forward. And thank you all for being here today. So as we get started, I want to start with Stefan from a sort of the macro level and just ask you a little bit about some of the really exciting new stuff. I alluded to a couple of the things at ONC and at HHS. And if you could just sort of open it up with a couple minutes of comments on that, it'd be greatly appreciated.
Sure. Can you hear me okay, Daniel?
Perfect.
Great. Well, first of all, thank you for having myself in ONC be part of this call today. You know, as you mentioned, ONC is certainly always been looking at consent and electronic consent and consent management challenges and issues for years. And although, maybe I could say that, we feel that we've always covered human services and social services because, at our core, ONC is focused on health IT adoption and utilization and standards to support that adoption utilization, whether that be, traditional private healthcare, whether it be, social services, human services, whatever that intersection is. And we've worked with our federal partners across many other agencies, but potentially in the past deferring for them to lead on a lot of that work when it was in the health and human services sectors, right? So we have worked for a long time on consent management issues with SAMHSA, with HRSA, with other agencies, and NIH, et cetera. Some of that prior work was really focused on consent to share, data segmentation for privacy, some of the early days of a lot of that work, and we've continued to participate and work with them on that, lending our technical expertise wherever we can to try to figure out how we can kind of manage that at a at scale level. But to your point, there has been kind of a renewed vigor, if you will, or a greater focus on expanding ONC's activities into some settings that traditionally we weren't quite as active in, and maybe wasn't a heavy amount of our work. So if you think of the behavioral health, mental health settings, women's health settings, a lot of other areas that in recent years we've seen where there was a lack of standards and adoption, whether they be data standards, whether they be exchange standards, et cetera. We've been collaborating in a number of different communities, including some that you've participated in and led yourself at Stewards of Change. And so, we've been able to kind of monitor and participate in those over years. But most recently, we're really looking at what else can we do around consent and electronic consent management, partially because not just because of these other settings, but also even in the private side of healthcare, even in the context of biopharma, the clinical trials and research area. There is this lack of health IT infrastructure and ways to manage consent at scale, including payers, as all of them have been brought to the table and really are starting to increase, whether it's price transparency, whether it's the fact that payers are creating clinical records of their members and coming up with care management plans for their members. They're increasingly a greater and more definitive source of data and clinical data even about their patients and members. We realize that they all need to be on similar, or would certainly work a lot better if they were all using similar electronic consent management practices. The 21st Century Cures Act, we're very proud of everything that's in there and we've helped implement over this past several years. But we're also hearing from a lot of industry stakeholders that, opening up these APIs for access for third-party app developers and others is really also increasing a need to handle consent at a more granular level, but also to be able to handle it at a more at scale level. And it's coming up with ways for consistent practices of that. And just want to mention that also, I'm fortunate I get to work with OSTP in the White House on a number of initiatives that relate to health IT. And in the last year alone, some of the big initiatives we partner with them on around clinical trials, health IT infrastructure, cancer moonshot related activities, the Connected Community Health Initiative. These are all things where consent has come up over and over again as a way of reducing burden and putting more power in the hands of patients and their families. And so there's a lot of intersections across all this work. And we're excited to continue to increase what we're able to do in the space.
Thanks, Kevin. I'm sure that at the core of this is a lot of the FHIR technologies that are sort of embedded in the ability to sort of create that standard. So I think I've seen that, but I'm sure that is sort of at the core of a lot of the technological innovation that's happening, correct?
Yeah, so I mean, I think it's no secret that for a number of years now, we've been looking at our FHIR strategy and really early on increasing the awareness of FHIR and its potential to help support greater interoperability across healthcare and easier adoption of standards. And so, one of the things that I got to lead and be part of is the FHIR at Scale Task Force, which eventually became the FHIR Accelerator. And that is one that is actually just put out a job description, hiring post for to have someone lead development of an implementation guide. And if you're not familiar with FAST, it's the FHIR at Scale Task Force. It's looking at what are those common types of implementation guides or technical infrastructure needs that cut across all the other accelerators efforts. So it's not specific data for a specific purpose, but rather it's more about what is that core infrastructure needed to make any data accessible for a number of different purposes. So if you look at some of the other FHIR accelerators, such as Vulcan, which is focused on a lot of clinical trials, research related work, heavy involvement from biopharma companies and a number of other organizations, or DaVinci, which has more about value-based care and getting data to be shared between both providers and payers. They've both highlighted consent as being a core infrastructure need in being able to enable data sharing for all those different purposes. Codex as well, which is focused on cancer, is another one that is focused on it. So these accelerators we're working with, and they're all working with each other as well in a number of ways to try to figure out how they can map out the use of FHIR to make this much more seamless and easier and easier to adopt and be referenced in any implementation guide that's out there. So no matter what the implementation guide may be, when you're trying to share specific data for a specific purpose, even whether it's Gravity Project, right? Potentially there can be a fast IG that talks about the technical components to manage consent when doing it at scale.
So,
these are.
I was going to say that's a sort of a perfect segue into Mohammed's work in terms of the fast healthcare interoperability resource standards and the privacy consent on FHIR. So if I could just sort of shift over to that from an implementation perspective and have Mohammed comment on that, because I know he's been deeply involved with the work of the ONC as well as on the ground there. Mohammed?
Absolutely, yeah. So FAST basically started this project last summer to go over the state of affairs in consent, and we did an environmental scan there to kind of go over all the initiatives that are available and all the different entities that have been working on consent from both technical perspective as well as use case analyses of different areas, especially.
All right, I think we're having a little bit of bandwidth challenges. Is that correct?
Hey, while we're waiting on Mohammed to come back online, maybe I could just say a few additional things on the fireworks. So that's all new work that I was talking about in the referencing through the accelerators. But there has been prior work with FHIR resources for research and consent, consent FHIR resource, questionnaire resource, a questionnaire response resource, provenance resource, research subject resource, research study resource, and other FHIR resources used in research consent. So there's been past work that's been done that isn't specific to necessarily just the accelerators, but is going to be leveraged in reference to them. And again, for us, even if there's a work being led by states like California or Colorado, where I know in Colorado their Office of eHealth Innovation is exploring the development of a consent management utility, specifically to really help in supporting the human services sector. Potentially they can point to all these resources and just make it easier to plug and play as these implementation guides get developed. So, we've been bullish on FHIR for years. It's referenced in the Cures Act in a number of places. It's referenced in our certification program in a few places, when it comes to APIs. So we certainly, believe in its potential. There's a FHIR roadmap even for the TEFCA framework. So, in general, there's a lot of support for FHIR as a standard because of its plug and play adaptability and for developers to easily kind of point to and understand how to plug and play. But in this area of e-consent, we especially when it gets into segmentation, for privacy purposes and other things, in provenance, I think there's still a lot of work to be done, but we see a lot of that work already in play.
I think, Mohammed, are you back with us?
Yeah, I think I lost connectivity. I apologize. I don't know what happened to my internet here. Yeah, so I guess while I was disconnected, maybe this was covered, but I think the environmental scan that was led by FAST and led to a report that I don't believe has been published. That led to the definition of a new initiative to do maybe an implementation guide on the management aspect of consent, including, for example, revocation, notifications, use of FHIR resources and profiling to be able to cover some of the use cases that are not just about the enforcement of the consent decision, but also capturing the consent and sharing the consent, going from a form, a paper form, or a questionnaire resource to a consent resource, and some of the details of consent management. So that's been a part that was in a way a gap in the specifications, and I think
All right, I think you're back.
right.
A little bit of okay. Are you there still? I think you kind of come in and out. Maybe take off your maybe take the camera off. Sometimes that might be the bandwidth issue.
All right.
There
All
you
right.
go.
Am I able now?
Yeah, well,
And
just
my apologies. I think there is some weather condition here that might be leading to bad.
very well, could very well be.
Um, anyway, so I think what I was trying to convey was that the consent management aspect is something that was not as much covered by existing specifications, and there needs to be more profiling on some of the FHIR resources that are not directly involved in the consent process, but they are part of the broader ecosystem of consent management. And I think hopefully that work would lead to implementation guidance in that.
Mhm. Do you have a sense of timing on that at all?
I think that the work has just got started. I think the environmental scan, we submitted that report at the end of summer, I think in an August timeline, and I think that led to the approval of the work. And I think there was some, contract logistics, and there's the work that's going to get started pretty soon, from what I understand. That will have its own timeline, I guess, going through HL7 balloting process and all of that.
Okay. I wanted to just ask you a little bit about granular consent. Now would be a great time. I know you're involved with SHIFT and been involved with granular consent in a lot of ways. If you have a few minutes, you can speak about that.
Absolutely. I think the major focus for me in the last year after the FHIR DSRP was published is to sort of work on the nuances of the integration of data segmentation and consent, and both consent enforcement and consent management. So to be able to leverage data segmentation as a way of expressing granular consent preferences. And that is part of the work that's also of interest for SHIFT. So they would like to cover some of these use cases for granular control over sensitive or emerging sensitive classes of data like reproductive health and the more legacy forms like substance use. And so I've added some rudimentary implementation to the original LEAP CDS, which was the consent or the open source implementation of consent decision service sponsored by ONC a couple of years back. And we've been able to leverage that entire infrastructure, work with some vendors on the consent side to be able to do demonstrations on the full cycle of going from preferences that are expressed around sensitive classes of data all the way to enforcing them. That would involve also labeling data in the course of that process. So, so that's part of the granularity. I think that the other forms of the other dimensions of granularity, which is, for example, like the date period, data period, or the type of information that's being accessed. So that is sort of like more straightforward from a technological perspective. I think the more challenging part has been to identify different classes of sensitive data and then being able to enforce the rules accordingly. And that's the part that's sort of the subject of what SHIFT is interested in, and also other parties that are working on that. And also part of my focus in the last year, since about last year, since FHIR DSRP was published. I think the other update that is related, at least tangentially, is the new permission resource that's coming in FHIR. And that is also going to be used to have a computational way of expressing or computable way of expressing overarching policies. So there would be a uniform way in FHIR to express both consent policies and rules, as well as overarching policies in a uniform way to basically cover all authorization policies in the same consistent way. So that will also be part of this ecosystem eventually. That I've been working on that as well.
That's really great stuff. Let me shift now for a moment over to Mark, so we can hear a little bit about his focus and work on the consent profile within the Gravity Project's FHIR Clinical Care Implementation Guide.
Thanks, Daniel. So for those in the audience that don't know, the Gravity Project is a nationwide public collaborative that develops consensus-based data standards to improve how we document and exchange social determinants of health data nationwide across diverse systems and settings of care and social services. So this includes, for example, developing terminology standards for data for domains such as food insecurity, homelessness, or social connection. And it includes developing a FHIR implementation guide to exchange those data elements. And the Gravity Project leads pilots to help test and iterate those standards with real-world testing and use. The Gravity Project developed the SDOH data elements and FHIR implementation guide, which the Office of the National Coordinator integrated into version 2 of the US Core Data for Interoperability. So with that as background, the consent profile is one of the profiles included in the Gravity Project's SDOH Clinical Care Implementation Guide. As it currently exists, it is merely a profile for exchanging pre-existing consent information if and when the provider decides to exchange that consent information. In a sense, it is merely an envelope for exchanging and communicating what consent has already been connected in whatever form the provider maintains it, such as a PDF or perhaps structured data. As it currently exists, the consent profile does not perform any data segmentation or tagging. So clearly, it is not a complete treatment of the issues related to consent, but it is a starting point to begin testing the exchange of consent information with SDOH data. Daniel, do you want me to talk a little bit about the OCR guidance? And
Would be great. I also want to remind folks who are on the call that if they have questions in Q&A, put them in, and we'll get into those shortly as well. But yeah, please go ahead, Mark.
Sure. So obviously, people are considering what are the privacy and security rules for exchanging SDOH data for better care, better health equity, when many of the organizations providing services or acting as intermediaries may not be HIPAA-covered entities or business associates. So I would offer several thoughts, observations. First, community-based organizations and social service organizations have been providing care and services to individuals for a very long time. So there are systems and practices already in place, although not necessarily the level of protections in the HIPAA privacy rule. Second, in 2021, the Office for Civil Rights issued a notice of proposed rulemaking. And in the background, it gave some descriptions of the current privacy rule. And it stated that the current privacy rule permits covered providers and plans to disclose protected health information, PHI, without prior consent to third parties, such as community-based organizations, that are providing health-related, social, and community-based services. So this might be, for example, the disclosing providers' treatment activities or healthcare operations, or the disclosing plans' healthcare operations, such as coordination or management of treatment. And an OCR gave some examples. So for example, a provider may disclose PHI without a patient needing mental health care supportive housing to a service or agency that arranges such services for individuals. Also, a health plan may disclose the PHI of a senior citizen without prior consent to a senior wellness center as part of the plan's wellness program in which the senior citizen is enrolled. And one thing that OCR did say that's a little different, it said that the minimum necessary standard, which usually does not apply to treatment, would apply in these situations. So some guidance from OCR back in 2021 that exchange of SDOH for better health, better care, better health equity can occur to third parties without prior consent in those situations. The third and final thought I'd offer is a California example, the data exchange framework and data sharing agreement. Statewide exchange framework, which includes community-based organizations and social service organizations providing health services to individuals and communities. For participant CBOs and social service organizations, the framework's privacy and security rules require that they nonetheless comply with HIPAA's privacy and security standards, including authentication and authorization, minimum necessary standards, and access, disclosure, and use only for permitted or required purposes. So I mention this because this should be a really good model for us to watch, both for California and for the nation, to see how this works and to learn from that and integrate that with all the other good work that we're all hearing about on this webinar. Thanks so much.
Thanks, Mark. Lots going on there. I'm really glad you brought it back to California, in particular, given all of the work that's going on there with the data exchange framework and CalAIM. And that's actually kind of a nice segue over to Kathy, who is on the other coast, actually taking all of this work, the standards work and the technologies and the legal and wrestling all of her policy people at the state and the county level and the hospitals down to the ground. We've had the good fortune to really sort of learn alongside of her and her team as it's implemented. And I'm really excited, especially since New York has just gotten their 1115 waiver approved, right? So I think that there will be some very interesting maybe applications of learning that can go back and forth between the coasts and everything in between. So Kathy, over to you for a bit on what's happening with these topics.
Okay, so thanks, Daniel and Mark and all. Just to set a little context for folks, New York's health information exchange environment is an opt-in environment already. So while data can flow from providers and CBOs into the 6 HIEs that New York State has certified, we can't release it to anyone without the consent of the patient to share that. Right now, and I'm using those two words very deliberately, that consent is facility or organization specific. So if you're getting care at CBO 123, you have to sign a consent there. In 6 months or so, we will probably have an all statewide consent. There's new language and a new consent form in the process of working its way through the approval process, where the language will be that a patient is consenting to the access to their data in the SHINY, which is what the New York State network is called, for any current and future treating provider, health plan, or CBO that is providing services to them. So I was just very excited about what Mark ended with, because there's still huge amount of discussion going on in New York about, well, what should the CBO be able to see? I mean, they shouldn't get access to the whole clinical record. Well, maybe they shouldn't, maybe they shouldn't. It depends on what they do for that person and what the relationship is and what the person is willing to share with them. So much more to come on that, but our experience has been quite positive. Everybody always said, what a burden to have to get consent all the time. Well, it's not. You ask and the person says yes, and it's one and done. 97% of the time in New York State, they say yes. The bulk of the time they don't is if it's a behavioral health or an SUD situation, and those are totally understandable. Right now, we're doing most of our consent collection in EMRs, which is fully electronic. But as Daniel mentioned, the ink is just drying on our new 1115 waiver, which will create a major information sharing network between health and social service organizations. That the SHINY is going to be the data highway. We're going to have social care networks that work with groups of CBOs and health plans who are going to pay the Medicaid money to the CBOs. But that information about who needs what social services, who has what social needs, has to move from one place to the other. And we're looking at various models, because New York is still pretty insistent on an opt-in consent, that the patient should say yes even and specifically for social needs screening data to be shared. Because again, everybody's hung up on this covered entity thing. And that issue of what should they see? Should they see the whole screening? Well, maybe not. If they're a food pantry, do they need to know there's, some other health-related social need? So the segmentation question is going to follow, but right now we're looking at a much more global level. Yes, you can share it, or no, you can't. The other issue, the one reason New York has opted to be and remains largely a opt-in state for HIE data sharing is that it allows us to share the patient's Part 2 data without obtaining additional consents. Going to opt out, as has been discussed many times, would require everybody who wants to get access to a patient's Part 2 data to get a consent, which when you start asking for it there, you're now getting into that gray area of, well, I don't really know if you have problems there or not, but I'm going to ask for consent in case you do. And it's much easier to just one and done. Yes, consent to everything, or and we do audit, I will say. We audit access to make sure that the treatment relationships are in place, and we almost never find issues where people have access to person's data who did not have a relevant treatment relationship with them. I think the final comment I would have is, as we move towards the CBO becoming more interconnected with the rest of the world, the whole idea of consent collection there and how to share those consents from organizations that don't necessarily have a strong technical infrastructure. They may not have a fully fledged EMR. They may have a place they could put it in an Excel spreadsheet. And how do we share that? I've done a lot of work with Daniel and many of the rest of the crew here on electronic consent utility implementation to see if maybe we can, pull it out of the individual application and put it where it could be better managed by the patient, and much more accessible to all types of organizations. So much more to come here in New York on this, and we're looking to California as being a little bit ahead of us and hoping to learn there.
Hey, Kathy, I'm just interested, has there been, I think I know the answer to this, has there been state-to-state consultation in terms of some of the, the heavy lifting that has gone on that you're aware of there?
Yes, absolutely. The New York State Health Department and Medicaid folks have talked to California and North Carolina and Oregon and everybody else who's been heading down this road ahead of us. Everybody's doing things a little bit differently. And some of the things that work in North Carolina that people here are talking about may or may not work in New York City. They might work upstate in the more rural areas that are much less population dense. But we're at the point now, literally this waiver got signed 10 days ago-ish, got released last week. The health department's RFA for social care networks and the real details of how this will work just got released this week on Monday. And so we're still just weeding through what New York is really thinking about the implementation details. We were very lucky to be able to get some of the Gravity folks, Gravity Project experts on the Gravity terminology and FHIR as well, talking directly to the state health department about the data sharing and the granularity and how this can work, so that they could be better grounded perhaps in some of the real world implementation pieces. But we've also been having great back and forth with the Gravity folks on the particularly the FHIR IG for social needs, and we're all looking to share that nationally and try to work across as many states as we can.
Yeah, let me ask Stefan, put you on the spot here for a second, like I want to do. I know in the CDO HHS data strategy, there's discussion around learning, really creating a learning environment for states and communities to bring that knowledge together, both from a training perspective, but also from a sharing perspective. I don't know if there are any concrete plans yet at all, but I would want to sort of lift up this work, particularly New York and California, Washington, Colorado, as some initial places where that kind of fundamental learning can really be brought together. Certainly one of the areas that we're interested in. Thoughts about that?
Yeah, no, I've been fortunate to be among a few of ONC staff who's been participating in the development of that HHS data strategy. And what we wanted to try to do in addressing that and mentioning that work is recognize, number one, that there is work already underway at a state level, and we want whatever we do at a federal level to be able to plug and play and work and be leveraged with what's going on at a state level as well, to build on that rather than try to compete with or start from scratch. And then also do it in a way that it can help complement and be done to support those. As far as specifics on progress made to date or specific actions, I can't share any of that quite yet. But I can mention that that's not the only place. The strategy sometimes reflects work that's underway as well as new work that's going to be planned. And I can tell you there's a lot of other federal initiatives underway that intentionally the data strategy worded it like that to make sure that it's going to be in alignment with it. And so, for example, there's work underway under the Cancer Moonshot dealing with developing data standards for pediatric cancer research data. And specifically in there is a call out to developing some guidelines for consent management as it relates to enrolling patients in clinical trials and tracking the data and so on for research purposes. With that adolescent or childhood cancer related care and treatment and research. So in there's a whole section in that work that references the need for being able to track consent, segment consent, be able to revoke consent, et cetera. And that work is underway. So that is one specific action and a specific initiative that aligns with the HHS data strategy that is kind of underway already, and then we expect to see some more outputs from that in 2024.
That's great.
And there's a number of other places, but that was just one example.
Yeah, no, it's great. It's great to be able to, now that we can begin to orchestrate some of this work, because there are places that are doing it and people who are actually moving forward. So I'd like to pivot. We have 10, 12 minutes left. I want to do a little bit of Q&A. I know that we don't have a whole lot of time here. But, one of the key questions here is really relating to equity, right? We're asking people for data, to share their data, and to trust the organizations that are, asking for it and sharing it around. A while ago, this terminology of sort of consent is equity in action. And I have certainly an opinion towards that, but I want to throw it out to the group just to say a few words about how do you see and how have you heard and what kind of conversations are you having around equity as it relates to consent and data sharing? A very light topic that we can accomplish in just a few minutes, but any thoughts on that?
Daniel, I can share a story. I convened some people in California to discuss HIE principles, and there was a discussion about the role of consent, and quite a mix of people. So one person working for a privacy organization was voicing quite strongly the need to require opt-in consent. Somebody must consent to sharing data before it could be from the individual, before it could be used, to which another participant sitting around the table who led a health clinic within a Native American community looked quite astonished and said, but if you do that, if you withhold the information, the community does not get the aggregate data that it needs in order to identify and address health disparities and try to improve care for the community. So I just lift that up as one example that there are sort of individual equity perspectives, there are community equity perspectives, and it can be complicated. Good to consider the different contexts and cultures. Thank you.
Other perspectives?
I mean, I'll just mention real quickly that we've seen certainly in the behavioral health setting and maternal health setting that having different consent policies and having some patients being able to revoke or segment or manage that consent in the sharing of certain data elements is not only leading to specifically life and death, different outcomes for different, so geography matters in that case, right? Depending on what state you may live in and how that policy impacts you may determine the quality of care you get, the coordination of the care you get, and in some cases, even criminal penalties that might be issued in relation to it, which creates obviously certain populations, the environment for them not to want to pursue getting the quality healthcare that they need, or, for fear of it. So there's a lot of issues and examples where, a lack of having good quality standard consent management practices, and to be able to do that, at scale between different stakeholders, is impacting different populations based on geography, sex, race, economic status, all kinds of things like that. So, we firmly believe at ONC in health equity by design, as Mickey Tripathi would say, our fearless leader, and building that into every practice we do, and every activity. A lot of the work that we're doing under USCDI relating to SDOH-related data elements, relating to SOGI-related data elements, related to race, ethnicity, and language-related data elements, behavioral health-related data elements. We're making this data more available through that, and we have to be cognizant of the potential good things that can come from it, but also unintended consequences that can come from that data being shared around. And having a fail-safe of good consent management practices, I think would empower a lot of populations to better manage that data once it starts to flow around. As we know, in most cases, the consent is, when it's done and it's given, for the entire medical health record, unless there's some law specifically in place that, protects or, requires that data not to be shared. So like mental health data in one case, right? 42 CFR, but otherwise it's, all or nothing. They consent to it and they get all the data, or they get none of the data. In a lot of cases, that's how the systems are built today, for the most part, with some exceptions. And we need to deliver a better health IT infrastructure for all populations to avoid these equity challenges.
And really quick, I want to just mention maybe a rather counterintuitive point here, that while the emphasis is very fair and due to have as much granularity as possible at the technical level to allow the flexibility to enforce different rules, exposing that complexity directly to the patients is also counterproductive for equity, because it would unduly burden some patients to make decisions at a very complex level. So that buffer, the interface and the user experience and user interface that would allow in the best way for the patients to make those decisions without overburdening them with this decision making, I think is also very important to highlight here.
Thank you.
Can I just jump in, Dana, for a sec? I have a somewhat different perspective on this as someone who was on the provider side for a long time and has been in health IT and public health as well. I think that there are obviously very, very strong reasons for granularity in certain ways, giving the patients as much control as possible over things. However, I've also seen many examples from the care delivery side where a provider did not know something that was really important to fully understanding how to appropriately care for that patient. And in many cases, that's due just to, silos of care and prior to HIEs and things like that. But most patients are not medically educated well enough to understand all the different types of information that a provider might need to know to have a full picture to treat them correctly. And I think it's important to recognize that a huge number of the folks in the provider community are very responsible about how they handle that. I recognize there are huge disparity issues with provider training and sensitivity and cultural understanding that we really have to work on. But I think, at least from sharing with providers, there are also huge risks to withholding a lot of data that, in fact, may be really relevant in a way the patient doesn't understand.
Well, I think that we're just beginning to touch on some of the really sort of volatile aspects of what consent requires and enables. And as I said, this is a much longer conversation. I want to turn to final comments, but I also just want to mention that in a lot of places that we've had these conversations, doesn't work. People keep reverting back. Number of people keep reverting back to paper and wanting to actually interact as the user interface on paper because they want to take it home. Heard this in the Bronx, actually. They want to take it home and talk about it with their family because it's a big deal. In some instances, it's even a bigger deal. So we won't have time to dive into that now, but I want to recognize that there are certainly, while we're looking at sort of, the Jetsons in terms of, technological solutions, we need to also remember that there are people here and that we need to make sure that people understand so it's not coercive, that it's understandable, it's in a language in the context that truly is understandable. And I think that is really underscores the importance of equity. You're enabling people to say yes or no with this fully understandable a fully understanding of the issues as possible in the amount of time and the complexity of this topic. So as we just pivot to the last few minutes here, I want to just give each of the speakers just a little less than a minute to say what's your key takeaway from this work. What do you want to leave people with today? Mark, do you want to start with you?
Sure. I think I'll pick up on some of the conversation in the chat. The webinar today is talking about consent, but consent is just one of the tools in the toolbox used used collectively to protect privacy, security, personal choice, and dignity. In my work, I try to tailor this collection of tools to the use case. And an example would be reproductive health data, where we see that we're within the past 10 years, we've had to pivot quite a bit and find different ways in different places to do that. So I'll say my takeaway is that using a comprehensive approach to privacy and security with a balance of tools, including consent, means that patient consent does not have to bear the full weight of privacy protection, which it never could do. Thanks.
Kathy, you want to go next?
Skip me for a minute and come back.
Okay. I'm gonna go to Mohammed.
All right. I just want to emphasize that there's been a great deal of work in the past couple of years in consent. A lot of the gaps in the specifications being filled, and there's better coverage now. The technology is there and is maturing, but I do want to emphasize that the next level of maturity for all the specifications and implementation guidance should come in tandem with actual pilots with real data. So we've done a lot of demos. There's been a lot of work done in that regard. I think it's time to take it to action and bring the feedback from the ground back to the specification development so that we can, go to the next step of maturity for these standards and implementation guidance.
Thank you. Stefan?
No, I just wanted to say, again, I hope there's more forums like this to keep highlighting all the different efforts that are underway and ongoing, like Mohammed mentioned. I'm excited about all the different efforts going on. What I'm concerned about is that they don't coordinate enough with each other, and then you have a bunch of different siloed approaches that when you need to link them up together, they don't connect and work. So that's, I think from a user-centered design perspective, there are definitely tools out there on the market. I think there's a few commercials in the chat from some folks who are promoting some of their products or talking about some of these opportunities. But there's a lot of products out there who are doing it, but they're doing it for specific use cases in a lot of scenarios, like in a research context for clinical trials, or there's consent management tools for other purposes, right? Coordination of community-based services or something like that. So I think the widespread adoption and having the ability for these tools to be built on the same types of standards, so it is easy to plug and play them all with each other, and you can track and manage that consent, have the right provenance for it across different systems and across different settings, is something that I would love to see a little bit more work on, a little bit more coordination on. It's something that ONC may be looking to play a little bit of a bigger role in it. It's continuing to try to create those forums and be part of forums like this to make sure people are aware of all these things that are going on and get some general consensus about some of the foundational elements needed to ensure that consent management related data can be interoperable, and that data can, be part of metadata that goes along with other requests and data and things like that. And the other thing is, ONC is looking at, are there other ways we can partner with our sister agencies and with the, external stakeholders on creating, better tools specifically for patient-facing tools to be able to kind of be involved in the management, mediation, et cetera, of their consent, revocation of it, et cetera. So education, we've done some of that work in the past. It's been a long time though, so not sure exactly what we're going to be able to do there, but we are exploring that and hope to continue working with all of the stakeholders on this call on those types of efforts.
Thanks. I'll beg your indulgence for one more minute. I want to give Kathy the last word here before we cut off.
I think we can all see from comments my colleagues have just made and the conversation going on in the chat, the technical side of this is actually the easy piece. The much harder piece is the conversations we have to have and the education that has to happen. And that is honestly evolving much more quickly than it ever did before because we've enabled consent technologically in many ways. Still a long way to go with that, but I think it's forcing the conversations about granularity of consent and education about consent, and it's only a good thing.
Thanks. Thanks so much. Thanks, everyone. Thanks to the panelists for joining today. I hope folks got something out of the conversation. I want to thank Timmy as well and Blue Path Health again for your time. This will be recorded. It'll be shipped out to folks, and I think we'll also capture all the questions that we didn't get a chance and all the comments. We'll make that available to folks. Timmy, did you have a last word you wanted to say before we sign off?
Thank you so much. It was fabulous. Boy, we have, with this being our last of our series, it really feels like we've got another whole series to host this year. So a lot for us to think about, and it was just so great to be able to learn about even more activities and projects. And please join, I put it in the chat, join us at Connecting for Better Health to continue this discussion. We meet twice a month. We highlight really great projects there and also entertain really good discussion. So join us, and thank you again for everyone.
All right. Thanks all. See you along the way. Have a great day. Bye.
Take care.